Good morning, everyone. Welcome. Before we get started, I just wanted to mention briefly the sound system, which I know a lot of people have commented on over the last several weeks. We've been working with classroom services to get it fixed, and they're actually here today to make sure that it's working okay for us. So fingers crossed, it'll work much better this week than in prior weeks. So our speaker today is Dr. April Stempien-Otero. She did her undergrad work at Dartmouth and then went to University of Connecticut for medical school before doing residency and chief residency at the University of Virginia. And then she came here to UW for her cardiology fellowship and has stayed on as faculty in the Division of Cardiology. She's now an associate professor of medicine, and she's also, interestingly, an adjunct associate professor of pathology. She does clinical work in the outpatient setting in cardiology here, in addition to attending on Cards B. And she's very involved in the transplant program, sitting on the transplant committee for all of our patients here who get hearts. She does a lot of teaching and mentorship. She has mentored trainees from the undergraduate all the way up to the fellow level. She does a lot of didactics for the fellows, teaches a lot of CME courses, particularly on heart disease in women. And she has won numerous awards. She's won awards for her research, the NIH Mentored Clinical Science Award, the AHA Physician of the Year Award for the region in 2004. And she's also won awards for her teaching, so for outstanding CME faculty, for cardiology teaching, the list goes on and on. But she's here today to talk about her research, and she has lots of grants, lots of ongoing projects related primarily to cardiac fibrosis, and she's done a lot of work recently looking at the use of stem cells in cardiac ischemia and fibrosis. So she's here today to give us her talk, Regulation of Cardiac Fibrosis, Insights from Cell Therapy. Please welcome Dr. Stempien-Otero.
The sum of that is I do too much. So I'm talking about, this is my title slide. I just want to preface this by saying that if there are any members of the media, the data shown herein is embargoed until after Monday. So do not report this on Twitter, blog it, or whatever. I have no disclosures. So I'm sure you see this slide about 5 times a year. Heart failure is bad. It's common, it's costly, it's the #1 Medicare discharge diagnosis and redischarge diagnosis and redischarge diagnosis and redischarge diagnosis and readmission diagnosis. And I think critically, with the baby boomers hitting their stride right now, you can see here that about 10% of baby boomers, males, have the diagnosis of heart failure. So the population with heart failure is increasing. We made great strides with heart failure therapies in the 80s with the development of angiotensin blockers, which were really the first novel new drug for heart failure that impacted mortality significantly. In the 90s and around the turn of the century, we were able to repurpose several older drugs, beta blockers and aldosterone inhibitors, and show that they also had additive benefit in mortality from heart failure. But really over the past 10 years, therapies have stalled. We have pretty interesting dramatic therapies like internal defibrillators to prevent cardiac death. We have LVADs now, implanted heart pumps that will prolong lives in patients with end-stage heart failure. We've had transplants throughout, but LVADs and transplants are really kind of a boutique therapy for the patient with end-stage heart disease. And so we have a big gap here in novel therapies to today. And I like to argue that part of that gap is because the current therapies we have really deal with helping the cardiomyocyte in the failing heart adapt to the failing heart, but in reality, 2 primary histologic features, structural features of heart failure have yet to be addressed. One is the fact that heart failure is a disease of myocyte loss, be it from ischemia or genetic causes, and as we politically correctly say, myocytes are essentially non-replicative. And so we cannot replace the myocytes. Secondarily, with myocyte loss and with increased stress on the heart, there is abundant fibrosis in the heart. We know fibrosis is an end-stage effect in many organs of disease, but in the heart it can be particularly deleterious to function. So outline of this talk today, I'm going to start by talking a little bit about how our work in cardiac fibrosis using mouse models and human tissue, And I'm just going to parenthetically say that if you're looking for signaling molecules, I'm not going there. I'm happy to discuss them later. I know you're crushed. But I'm going to tie that into small animal studies and clinical trials in stem cell therapy to treat myocyte loss and pull it together how that's led to us performing a very interesting translational stem cell trial. So cardiac fibrosis is the accumulation of excess extracellular matrix. Predominantly fibrillar collagen. Fibrillar collagen has the tensile strength of steel, which is great if you want to build a scar, not so great if you want to pump an organ. It's found in end-stage heart failure independent of etiology. So no matter what your cause of heart failure is, valvular, ischemic, idiopathic, hypertrophic cardiomyopathy, every single one of those hearts that we look at when we cut them open looks like this, in which the collagen is stained red here. And there are no effective therapies for cardiac fibrosis. Clinically, it's bad. It impairs relaxation and contraction. And we always think of it as stiffening the heart and impairing relaxation. But in reality, you can think about those little myocytes trapped in here. They can't contract either. They're basically pulling along all of that fibrous tissue with them. It promotes arrhythmias, both atrial fibrillation, the bane of all of our existence in this room, I'm sure, in the atria, and ventricular arrhythmias. There's been some great studies where they've actually done electrophysiologic mapping, which maps areas of ventricular arrhythmia generation to fibrotic areas of the heart. And finally, it may be a barrier to cardiac regeneration. So as we develop myocyte replacement strategies, we're going to need to deal to some effect with the fact that there's existing fibrosis. So I became interested in this when I entered the field of heart failure. And some, Bill, may remember that my first grand rounds here many years ago was actually in an era where we were very interested in the concept of pro-inflammatory cytokines in heart failure. There was a whole host of studies on pro-inflammatory cytokines in heart failure and blocking them, and they came to naught. But what was left over was this lingering issue that there was inflammation in the heart in end-stage heart failure. And in particular, there was an abundance of macrophages in the heart. And that macrophage density correlates with the amount of collagen in the heart. This is a great study where they took patients who had low ejection fractions, ischemic cardiomyopathy, and did biopsies at the time of CABG, and then correlated areas that improved to areas that didn't improve. And they showed that areas that normalized were those with lower macrophage density and therefore lower fibrosis, which makes sense. And not only are macrophages and fibrosis correlated, if you look histopathologically, they are actually together when we look at end-stage hearts. So these are human hearts. The red is fibrillar collagen, you can see here in the interstitial space, and these dark brown dots are CD68 stain for macrophages, and you can see that the macrophages are peppering this fibrotic area. So they're associated on a global scale, they're associated intimately within the tissue, and I started asking the question of what could be happening. So we all know that macrophages play an important role in tissue injury and repair. And again, when I started this research, really the M1 pro-inflammatory macrophage was what most of us had studied at that time. But a second wave of macrophages was found to be important. And in reality, these work in concert with to repair injured tissue, in which the M1 macrophages that elaborate pro-inflammatory cytokines come in putatively, INOS to kill the bacteria, MMPs to degrade the injured tissue, followed by the M2 wave of macrophages, classically stimulated by Th2 cytokines, IL-4 and 13. And these elaborate a host of factors that turn off the M1 macrophages and then induce local fibroblasts to initiate repair. In an ideal situation, and potentially I'd argue probably happens best in organs where there is regenerative potential, these two phases come and go, and there's resolution of the injury and regeneration of the injured tissue. However, a model is rapidly evolving that when these don't get turned off, in particular when this M2 does not get turned off, that it can lead to chronic inflammation and fibrosis. And I'd argue in the heart, in which there's no regeneration, could be particularly susceptible to chronic M2 activation because of the fact that we don't have the regeneration to turn this off. So I became involved in this soon after fellowship. When I was doing congestive heart failure, I wanted to do to expand my lab work in heart failure, and David Ditchek came up, and he had a fascinating model of a transgenic mouse with a macrophage-dependent transgene that had spontaneous fibrosis. And you can see here, this is the transgenic mouse with this white stuff on the surface, and the non-transgenic, which is completely normal, litter mates. He had initially developed this mouse to look at the role of urokinase in plaque rupture, but when we took this and bred it back into just a wild-type mouse without any atherosclerosis, this fibrotic phenotype persisted. So I was really interested in this because one of my pet peeves had always been that all the research in heart failure at this point had been really focused on cardiomyocytes. So here we have a macrophage-dependent cardiomyopathy. And when you looked histologically, at 5 weeks of age, these mice developed spontaneous accumulation of macrophages in their ventricles, followed at 15 weeks by spontaneous fibrosis. So this is no injury, no hypertension, no MI. They just spontaneously develop this. And I'm not going to go really into the mechanisms of this, but this link between the macrophage accumulation and the fibrosis led to a bunch of questions that I've answered over the past several million years. The first is, in relation to this model of the M1, M2 macrophage, is the excess cardiac fibrosis with macrophage accumulation associated with M2 macrophages? And then is it just this crazy mouse, or is this a normal process in normal cardiac repair that occurs? And then finally, the mouse is all well and good, but is this something that we see in humans? Are those macrophages that I see crawling in the interstitium histologically also M2 polarized? So just briefly, a lot of our methodology in the lab has involved isolation of different cell fractions. And you can notice here that we consider cardiomyocytes debris. So we're really trying to get to the different cells that are initiating processes within the remodeling heart. And what I'm going to focus on is we use CD45 to get macrophages. It's a pan-leukocyte marker. It gets all white cells, but in our models, we're at points where most of the white cells are macrophages. The remainder of this non-myocyte fraction, I'm going to call fibroblasts. It is a mixed fraction of cells, but predominantly is made up of fibroblasts, which I will parenthetically say are the most common cell in the heart. So our first hypothesis, does excess cardiac fibroblast production in our mice, is it associated with M2 macrophage activation? And so again, looking at the time course with the picroserous red stain for collagen, you can see 4 to 5 weeks to 10 to 12 weeks, we have a gradual increase in collagen accumulation in these mice's hearts spontaneously. And when we isolated the macrophages and measured 2 of the prototypic M2 markers, arginase and YIM1, you can see that the fold expression between 5 weeks and 12 weeks goes up dramatically in these isolated macrophages. So with time and in coincident with increasing fibrosis, there is increasing expression of M2 markers from these macrophages. Not saying it's cause and effect, but it correlates. And when we look at other cells to make sure this isn't just a total body process, bone marrow macrophages from the mice at the same week have time point. This is at the 6 to 8 week time point. So the bone marrow macrophages have essentially no expression of these. The other cells in the heart, the cardiac fibroblasts, have no expression. This is really isolated to the cardiac macrophages, this upregulation. So this is interesting. We have macrophages coming into the heart. They're associated with fibrosis. They're M2 polarized, but this is kind of a little bit of an artificial system with a transgene. So our next question was whether or not M2 activation was present in normal cardiac injury repair. And for these experiments, in collaboration with Alina Manami, we performed myocardial infarctions in mice, which are very small infarctions, in which we ligated the LAD, and we looked at the mice at a 7-day time point post-infarction, which is really that transition time point between inflammation and repair. And just briefly, what we showed is at this 7-day time point, when we looked at this fibroblast portion and measured expression of collagen, you can see that the infarcted mice have significantly more collagen expression in their fibroblasts. And coincident with that, when we look at the macrophages, we have an identical pattern of upregulation of these M2 markers. So again, we have correlation in an infarct model that during repair, when you're transitioning to collagen accumulation, it is associated with these M2 markers. So finally, mice, all well and good. What about people? Because every day I see people in my clinic, I see people with end-stage heart disease. Normally at this hour, we're in transplant meeting, agonizing about if an end-stage patient, we have any therapies like LVAD or transplant. And so for these studies, we took patients who were undergoing LVAD placement, and simultaneous in the same day, I took blood in the morning and then took their LVAD core at the time of explant of the core for the LVAD. So you all know, anybody doesn't know, we have to cut out the little apex of the heart to fit the LVAD in. Provides a great experimental model. So we took blood-derived macrophages and cultured them for 7 days, monocytes, cultured them for 7 days to turn them into macrophages. Simultaneously, we isolated in the same day the CD14 positive macrophages and CD14 negative fraction, which we again call fibroblast, although it's a mixed fraction, and isolated RNA. And then we compared expression of human M2 markers between the blood macrophage from the same patient and their cardiac macrophages. And these are the data. Each different shape represents a different patient here. As anybody who does patient research knows, there's a lot of heterogeneity in patients, and so we try and use patients as their own controls. As a positive control, we took the blood macrophages and we stimulated them with interleukin-4, which is this prototypic M2 stimulator. And you can see that most of them went up nicely with expression of the mannose receptor, which is also CD206. So we had a nice M2 response with CD206 to IL-4 from blood macrophages. And intriguingly, the cardiac macrophages isolated from the same patient at the same time without IL-4 stimulation were also expressing similar levels of mannose receptor. So this, again, without any expression in the fibroblasts, implies that we have M2 macrophages in association with fibrosis in the heart. And just to show that not everything goes up all the time, CD163 is a scavenger receptor that had been also reported to be an M2 marker in humans. You know, any of these studies, you comb the literature, you find what other people have done, and you repeat it, and you find out it doesn't work. And indeed, in our hands, on humans with end-stage heart disease, their blood-derived macrophages do not stimulate expression of IL-163 in response to IL-4, really. So they didn't stimulate, and likewise, they only had very minimal increase in this in the heart. So this factor that's stimulatable by IL-4 goes up in the heart, whereas this does not, except that one patient, does not generally. So we think that we have a specific response that's again, specific to the heart. So in conclusion, I think I've hopefully shown an association in our mouse models, in a transgenic mouse, in an injury model, and in humans that these M2 macrophages are present in association with fibrosis. And of course, our definitive studies to then reverse the process are ongoing in our mice first. But we began to answer the question, what about humans? So if these macrophages in the heart are all M2 polarized and M2 polarized macrophages promote fibrosis, what if we could somehow replace the macrophages within the heart with these sort of M0 or non-fibrotic macrophages? Would that have an effect of reducing fibrosis in the human heart with end-stage disease? So luckily, that experiment had been already done a little bit. So at the turn of the century, I like to call it the turn of the century. Makes me feel very, So at the turn of the century, there was a host of trials that were published, and I picked some of Chuck and Rob's favorite authors to highlight here. A host of studies that bone marrow cells can regenerate injured heart tissue. And these are some examples. They got really good press. They got published in Nature Medicine, that they regenerated the infarcted myocardium. In this study, they actually made cardiac myocytes. In this study, they became blood vessels. And in this study, they actually reduced fibrosis and improved relaxation. So this host of studies at different that bone marrow injection could improve cardiac function and injury, and potentially by regenerating different pieces of the heart. So these obviously led to clinical trials, and they led to a lot of different clinical trials in which people put bone marrow in intracoronary, intramyocardial, after acute myocardial infarction and chronic ischemic cardiomyopathy, sometimes in association with a CABG, sometimes as a standalone therapy. Most of the studies did mixed bone marrow mononuclear cells. A few studies started working on the specific CD34 stem cell population, but a host of studies, many of which had Ns of 10 patients, were published over a time period. And I'll just say that parenthetically, most of the intracoronary studies have been a complete wash. None of them have shown any benefit whatsoever. And the acute MI studies have also been essentially a complete wash and have not shown any benefit. But the studies in which they did direct bone marrow injection into patients with chronic ischemic heart disease, so the patients I fret about every week, actually seem to show some sort of benefit. So these first 3 studies are increasing numbers of patients, in which they measured ejection fraction and perfusion by using SPECT perfusion scanning, similar to the stress testing SPECT we use, and show that with injection of bone marrow mononuclear cells, there was improvement in perfusion and small improvements in ejection fraction in patients with chronic ischemic cardiomyopathy. And this was the largest study, having over 50 patients in it, and was actually randomized in a controlled manner, somewhat, in which saline was injected. And they showed improved perfusion and EF by MRI in these patients. Now, a follow-up study, this was done in Europe. Two follow-up studies in the United States have been negative since then. Although these had slightly higher ejection fractions than this one. And so there's a question as to what's going on. But there has been this trend towards improvement. So I started asking, okay, they're injecting bone marrow cells. I've been studying macrophages. What's in the bone marrow that could be delivering this therapeutic effect? Well, the first big exciting papers in which stem cells were all transdifferentiating into things were why people started the studies. But for the hematologists in the audience, they know that the CD34 positive stem cell population is really less than 3% of a whole bone marrow prep. So very few cells that could be magically transdifferentiating. And although this population does include this endothelial precursor population, about 50% of these cells can in culture turn into endothelial cells. The bone marrow also contains, most of it's actually developing and mature erythroid myeloid lymphocytic cells, platelets and megakaryocytes, mesenchymal stem cells, for which some people have also done clinical trials, and these are far less than 3%. They're 0.5% of the bone marrow. They're stem cells and mature stromal cells that have a fibroblast-type characteristic and have been shown in culture can be forced into being made muscle-like cells. And then finally, 20% of the bone marrow is just macrophages. It's resident macrophages or newly developed macrophages. So the big question for me was, are these macrophages, like in my heart, they're profibrotic, are these studies essentially reproducing the study I want to do, where they're injecting just a M0 macrophage and changing fibrosis and therefore improving function? Or are these hematopoietic stem cells the ones that are doing the action? So is it the stem cells that are either turning themselves into blood vessels or by paracrine effects stimulating angiogenesis? Are they potentially improving survival and proliferation of cardiomyocytes? And these are kind of the ongoing theories, in particular this one at this point, that you're going to improve perfusion by increasing vascularity from differentiation or paracrine effects of these CD34 stem cells. Or could it be a CD34 negative fraction, maybe an M0 MAC, maybe a lymphocyte, maybe somebody else, that's inhibiting fibrosis and also by paracrine effects, causing increased vascularity, all of which would lead to decreased fibrosis, improved function. So we sought to test the hypothesis that the CD34 stem cells are necessary to improve vascularity and decrease fibrosis in the ischemic human heart. So we tested the most commonly held belief about why these stem cells were working, and had been shown in animal models, but not really tested in humans. So we set up a unique model system, experimental design, taking advantage of the fact that we have a small population of patients who need left ventricular assist devices as a bridge to cardiac transplantation. And so we have time point A, in which their heart is exposed and available for injection, in which we could test different bone marrow fractions and use a saline control. And we could, within each patient, use them as their own control. So the saline area can act as a control in each patient. Then we have point B, where we get the whole heart. So we can analyze these areas that we've injected histologically and really test whether or not the CD34 stem cells are the goods that are going to improve vascularity and decrease fibrosis. So our study population is patients over 18. We used ischemic cardiomyopathy because, again, the theory being that they would most benefit from a therapy that would improve vascularity. There are also other studies showing that they have hordes of pro-angiogenic cytokines in their ischemic areas. So it's the most fertile garden we could think of to make blood vessels. And then using LVAD patients as a bridge to transplant. So patients that needed destination therapy were excluded. Our major exclusion criteria were anybody that needed an emergent LVAD was excluded because we needed 24 hours to process the bone marrow. If the patient themselves couldn't consent, I wasn't going to enroll them in their trial if their family members signed them up. And then what became a big problem was if you're on a balloon pump, I wasn't going to do a bone marrow aspiration on you. So to get to, this is a busy slide, but to get to these three different cell fractions in the saline, we went through a separation of the bone marrow mononuclear cells and a separation of the CD34 positive and negative fractions using a Miltenyi Clinimax machine. In the first two patients, we were able to label the bone marrow fraction with Faradex nanoparticles to see if we could track the cells and track differentiation of the cells in vivo. Unfortunately, after the first two patients, it was pulled from the market in the usual manner. We tested every sample by flow cytometry and gram stain to ensure that there was no contamination. We weren't going to hurt the patients. And the doses that we used here of about 1 million cells are basically the same doses that were used in the stem cell clinical trials, just scaled down to the single injection area that we were going to look at histologically. And I'll just say right now, we weren't trying to change function. We were just looking at these mechanistic endpoints. So here's a FACS analysis of one subject's cell fractions, just to show you that, yes, the CD34 enriched fraction had pretty much all CD34 cells, and that half of those CD34 positive cells were these CD133 endothelial stem cell fractions. And again, you can see the usual assortment of other hematopoietic cells. Again, we chose ischemic cardiomyopathy, and we very carefully chose the injection points from patient to patient for two reasons. One, so that there would be as much homogeneity as possible between patients in the areas that we injected, and two, to get these areas that we thought would have maximal benefit from revascularization and maximum possibility of revascularization. So we used SPECT perfusion imaging that had been done on the patients previously and shows areas of 50 to 75% perfusion. So they were about 25 to 50% ischemic. So slightly ischemic, not scar tissued areas for injection. And then again, in the operating room, each subject received all 4 injections with the saline control, with each subject acting as its own control. All the product, which was processed mostly at the Fred Hutchinson Cancer Research Center cell cytometry lab, was blinded to everybody in the study except them as to what were the contents of each vial. And they were rotated from subject to subject so that, vial 1 contained saline with one patient, bone marrow cells with the next patient, CD34. So we really had no idea what was being injected in the heart. The endpoint of this study, the major endpoint, is safety. This is a FDA phase 1 IND. And so our safety criteria was looking at the first 7 postoperative days, ventricular arrhythmias, and bleeding. So ventricular arrhythmias with stem cell injection has been a worry in the field for many years, so we wanted to track that. And then, of course, we are sticking needles into people having cardiac surgery. And so we wanted to make sure that we weren't causing undue harm from a bleeding standpoint. Our primary histologic endpoint to test our hypothesis, as I said, was endothelial density, which we measured by CD31 staining as a measurement of vascularity throughout the tissue, and fibrosis, which we measured by picoseries red. We looked at 3 secondary histologic endpoints, again, looking mechanistically at what the cells could be doing. One was just the total macrophage content, with the hypothesis that if you were making the tissue better, you should have decreased inflammation, total fibroblast content, and then proliferation to test these hypotheses that these cells were inducing proliferation of endothelial cells or potentially cardiomyocytes. The tissue, again, each segment was taken out at the time of transplant. We did 5 step sections. We stained them for the issue of the factor of interest. The CD31 was done computer-generated analysis. The others were done manually by lovely people in the audience here. And these 15 areas per section, so we had a lot of data from each, which gave us the total value that we used in our analysis. Our statistical analysis, again, each subject acted as its own control with the primary hypothesis that each cell injection versus saline would show an improvement. And then there was a correlation coefficient done between some specific treatment subgroups. So here's the intraoperative procedure. Let's see if this is going to work. Thank you, Nahush Mokadam, for this film. So you can see here what is happening is Nahush is tying in these little markers that we put in so that we could see at the time of transplant where we had injected the cells. I like to say where Nahush had injected the cells. And then what you're going to see he's going to do is, at this point, within here, he's going to make a little purse string suture. Because we discovered with the first patient where we injected cells that some of the cells came flying back at us after we injected them. So he came up with this clever idea to inject through a purse string so we could close it shut and slam the cells in so they would stay. So that's the purse string. Very pretty. And then finally, once the purse string is ready, the cells are injected. And so this is a total of 1 million cells injected in 0.25 milliliters. So we do 4 injections into each area of the same cell type so that then when we harvest, we can isolate 4 separate areas for analysis. My 14-year-old was like totally grossed out when he saw this last night. He was like, "You've got to be kidding me." So here's how our study enrollment's gone. We screened 26 patients that were scheduled for bridge to transplant LVAD. Of these, 18 were excluded. 5 spouses refused. They didn't refuse. Their spouses refused. 6 required emergent balloon pump before we could get the bone marrow out of them. 5 developed issues that came up at the last minute that made it clear they were going to be destination therapy, or it was going to be a long time before they were going to be transplanted, if they were ever. 2 patients had logistical issues. Most of our LVADs are done on Tuesdays. There are Monday holidays. The Fred Hutch isn't open, so those are patients that we just couldn't process the bone marrow. We had 8 patients consented for the study. 1 patient, the morning of me coming in with my trocar, said he couldn't take it because we'd prepped him for a colonoscopy for like 5 days, and he was just like, I can't take it anymore, leave me alone. He's still waiting for transplant. So we had 7 patients that we collected bone marrow in. I will say in one of these patients, we did have a low cell number, but they continued on to the intraoperative injection. Within the operating room, one patient whom we collected bone marrow and were ready to go became too unstable intraoperatively, and so we did not do the injection in that patient. Our characteristics were kind of our usual end-stage cardiomyopathy listed for transplant group. You can see the younger age predominantly because of they're going to be listed for transplant. We had one woman, and you can see that the big limitation of this study is that unlike a mouse study where every mouse gets sacrificed at 6 weeks or 8 weeks or 3 days, we have to wait for the humans to be transplanted, and we have no control over that. So we have a wide variety of time to transplant between 42 days between injection and collection of tissue to one patient who was over a year. Our safety data, which we analyzed after each patient was injected, and we did not enroll another patient until we had cleared with our safety monitor, showed that there was essentially no difference in blood use between patients who were injected, which are the blue dots, and the control patients, which were the patients that refused the procedure or couldn't have the procedure for some reason, on the left. And from arrhythmia standpoint, our biggest finding was that arrhythmias are really common post-LVAD. They're as common if you inject cells as if you don't inject cells. So neither of our safety points showed any significant safety issues. And here is the money slide. So again, our primary endpoint was that CD34 stem cells will increase vascularity. And in fact, the only statistically significant thing you see here is that CD34 stem cells decreased endothelial density in comparison to saline, with a trend towards the other injected areas also having decreased endothelial density. There was no difference in fibrosis between the saline and the injected fractions. And here's an example from one of the subjects looking at CD31 staining. Again, endothelium, you can see this, here's a nice blood vessel, endothelium, but a lot of these here represent likely capillaries. And you can see here the saline injected, of course I've picked best possible, but the saline injected clearly has many more CD31 positive endothelial cells in comparison to the other cell injected segments. Our secondary endpoints, I have expressed here in difference from control. So the dotted line here represents for each subject what their control value is, and this is the difference from control. So this is CD68 inflammatory cells per millimeter squared. You can see there's really no difference between any of the 3 injections or control. They all cross control. When we looked at alpha smooth muscle actin, which is a measure of fibroblasts, and we excluded blood vessel smooth muscle cells from this, we did see statistically, again, paired t-test compared to each patient, a decrease in the number of fibroblasts in the CD34 positive and negative fractions in comparison to the control fraction. Now this is a decrease from 5% positivity, from 6% positivity to 5% positivity. So we're talking about very small, tight numbers, but it was statistically significant. And surprisingly, there was an increase in number of proliferating cells in the CD34 treatment. So the CD34 treatment had fewer smooth muscle cells, fewer CD31 endothelial cells, but more proliferating cells. What you may notice here, and we noticed when we looked at the data, was that all of the cells kind of were all doing the same thing. And this looked, when we looked at individual patients, was very striking. So we did a correlation between what was happening in tissue injected with CD34 positive cells versus CD34 negative cells. And what you're seeing here is when you look at, for example, picrocereus red, this is percent collagen, and each of these different shapes represents a different patient. You can see for this patient, the correlation between the amount of fibrosis in the patient in the tissue injected with CD34 positive versus negative is almost a line of unity. And it's really striking statistically, which isn't here, I apologize, that the R values on these are over 0.9, and they're all statistically significant. So if you look at CD68, complete almost line of unity. So areas that were injected with CD34 positive versus negative had the same results when we analyzed it. In our 2 patients in which we were able to do cell tracking, we saw here, this is a H&E of the cell injectate area. When we looked up close, we did Prussian blue stain for iron to look for the Faradex labeled cells. You can see here in that area there's nice Faradex labeled cells. When we then did co-localization on serial sections looking for what was the identity of the Faradex labeled cells, what became clear to us was that the macrophages tracked completely with the Faradex labeled cells, making it likely that the cells that we injected had either transdifferentiated into macrophages or had died and become engulfed by local tissue macrophages. So we think it's most likely that these positivity represent local tissue macrophages that have engulfed the cells that were injected. And this is also potentially consistent with the fact that any cell we injected basically had the same effect, whether it was a CD34 positive or a CD34 negative. So in conclusion, I think our study's shown that injection of bone marrow-derived cells at the time of LVAD placement is safe and feasible, and that the CD34 stem cells do not increase vascularity and unloaded ischemic tissue. And I think that this has really put on its head everything that everybody thought was happening with injecting bone marrows into the heart. The injection of cells did have some cellular changes. There likely be via paracrine effects. There is some interesting data that apoptotic cells can have paracrine effects within tissue, and I think that that would potentially explain some of our data, but we'd have to further study that. That all cells go in, they die, they have a paracrine effect, because it is independent of the origin of the cell therapeutic. Each different cell therapeutic seem to have the same effect within the tissue. Obviously, the limitations of this study is we cannot say that this is exactly what's going on in the clinical trials, because the clinical trials are in patients with ischemic cardiomyopathy that aren't on LVAD. The LVAD patients are unloaded. It could change remodeling. It could change all sorts of things. And we have very small numbers. You know, we have able to do robust statistics because we use each patient as their own control, but it's likely that we have some both type 1 and type 2 statistical errors buried in our data. So I just want to acknowledge the team that helped with this study. Laura Derry have been my lab managers. Tabitha and Andrew Prowse, known to you, and Steve Ferris were all mega analyzers of histology. Nahush has the smiley face because he's so cheerful, who injected the cells. Suzanne, my nurse study coordinator. My collaborators, nuclear cardiology that analyzed all my SPECT images, and frequently on the morning of surgery, where are we going to put the cells? Helped me figure out where to put the cells. The ice cream histology core. This would not have been possible without the UW ITHS. I had to write my own IND for this and do pilot studies. So I received pilot funding from the ITHS, the GCRC, and the Fred Hutchinson Cell Processing Facility helped me with doing the IND, doing all of the quality control work that's necessary for a study like this, and were really invaluable. And then funding from my R01 and from the Tall Family Foundation that my chair is from. So throw me your best questions.
So thank you, April. That was a really nice presentation. So as you alluded to, the Heart, Lung, and Blood Institute has now funded 3 multi-center clinical trials in this area, none of which has shown an effect. And your study suggests that there's no effect either. On smoke and mirrors.
Well, you could say that. I mean, I'd like to look at it that, I think my study has shown that you can use these, you can look mechanistically at what's happening. I think that the major thing is you can't assume what happens in a small or even large animal model is going to be the same thing that happens in a human who's had a disease that's lasted for 10 or 15 or 20 years. I mean, I think that's been the take home for me in my study and looking at the clinical studies. Nobody? Oh, there's one over there.
So, I mean, ideally, you're using bone marrow-derived cells to generate cytokines and alter the milieu. Has anyone looked at actually enforcing gene-modified cells to express cytokines that will prevent differentiation towards a type 2 macrophage phenotype?
Yeah, so nobody's done that. So Susie Pun in bioengineering and Elaine Rains in pathology recently published some data where they were able to use a small molecule to kill off M2 macrophages in tumors. And they were able to ablate the M2s from the tumors and show a decrease in vascularity in the tumors. So we're actually looking at using that molecule in our models to get rid of the M2 macrophages and see if we can reverse the process. I'll point out that, the M2 macrophage has been shown in a couple of different tissues, but it looks like each tissue kind of has its own special M2 macrophage, so it's probably going to have to be done on a tissue by tissue basis. Eric.
What's the next step?
So my next step is we're really interested in these proliferating cells. So we're really interested in what are these cells that are proliferating in a situation where we have fewer endothelial cells and fewer fibroblasts, but more proliferating cells. So our next step is we're looking at studies in which we can measure proliferation of cells in vivo in humans using heavy isotope labeling of their DNA. So that's next step number one. And then seeing if that changes in response to cell therapies. Because we have a readout here. I think that, clearly we can use any cell. But that's really the next step that I'm looking at.
Will that make a difference?
Well, I think if we can judge the proliferating cells to proliferate into cardiomyocytes, that would make a difference.
Despite the fact that you haven't gotten rid of the fibrous tissue.
Well, so I just told you aim 1. Aim 2 is working on the fibrosis. So aim 2 is working on what is a particular mechanism that the M2s are driving the fibrosis. So we could block that.
Over here, April, to your right.
Chuck.
So why do you think this bone marrow hypothesis is so tenacious and resistant to being moved by data?
You're just asking David's smoke and mirrors question?
Well, I'm following up on it.
Well, I think
it's like this whole social phenomenon as opposed to a reason-driven thing. I'm just curious to what your thoughts are.
I think that the increased vascularity just looked so good, and there's so many studies showing these endothelial progenitor cells in the blood, and that they decrease with aging, and so that correlates. There's just so much tantalizing data that the bone marrow should make more blood vessels. That I think that is the major thing that has pushed it along for so long. I think it is starting to shift now that now people are starting to talk about bone marrow, in particular the mesenchymal cells, being immunomodulators within the heart. But I think what's pushed it for so far is the blood vessel thing. And in reality, I think the basic question before that is whether or not even making more capillaries has any effect in end-stage cardiomyopathy, which is a totally separate question. But I really think it's that wanting the end, because if you look at the companies that have developed, they've really pushed on the endothelial side. I mean, Miltenyi couldn't understand why they're a German company and they have the CD133 beads, so they wanted me to use those, but you need like 100 cc's of bone marrow, and I was like, they couldn't understand why Americans wouldn't just lie down and give up 100 cc's of bone marrow under local anesthesia like Germans. But I think that's been the tenacious piece, has been that wanting to make blood vessels. I think that the clinical studies have been driven by interventionalists who want to make more blood vessels, because that's what they open up the big artery and they still see problems and they just want to put more blood vessels in.
I was hesitant to ask my question or make my comments because they're really sort of a little bit out of the box here, given that you focus on end-stage heart disease, you focus on treatment, and you're trying to identify mechanisms that might point you into directions for novel therapies. Sort of in response to my friend David's question and Chuck's question, I would suggest maybe you're looking at the wrong population. Certainly as some of you know, I'm an epidemiologist, and from an epidemiologic perspective, there's increasing data with regard to determinants of heart failure in older adults. There's no question that what you see in pathology in terms of fibrosis, macrophages, inflammation are important. From our perspective, the question is, can we get information from accessible tissues like blood that would help us get insights into mechanisms, into prognosis, into potential therapies that might be used earlier in the development of heart failure to prevent fibrosis or to encourage a more adaptive response to the insults that lead to fibrosis. So I sort of throw that out for you because early in your presentation, you showed some data that looked at blood, looked at
right.
marrow, and so on and so forth, and then you got away from the blood.
Well,
I want to know whether if we look at macrophages, we can separate PBMCs and CD34 cells in peripheral blood, whether we should be looking at gene expression of those cells as potential markers, whether we should be looking at epigenetic changes in peripheral blood cells as potential signatures of who's going to go on to develop fibrosis. And then finally, I would just say that I like the fact that I like many of the things that you've done, and I applaud you and congratulate you. I mean, it's an incredible effort. But of course, when I say the wrong patient population, you're dealing with people who are on a lot of drugs, people who are under anesthesia. There are a lot of things that can happen acutely as well as chronically to inflammatory cells and to the response to inflammatory cells. So you've taken on a hugely complex issue, and I would suggest that you come talk to me. We'll see if we can identify some ways for you to do studies that aren't smoke and mirrors, that aren't sort of people using opinion to trump data, and so on and so forth.
Well, thank you. I would like to say that, I totally agree that the bang for the buck is in prevention. But what I see in my clinic is the end stage. And I see us using an enormous amount of resources and cost in those end stage patients. And so that if we could make an impact in those end stage patients, and as a heart failure doc, I see people that come to me with an EF of 20% that with beta blockers and ACE inhibitors have, go to normal function. Or even if they don't go to normal function, return to normal functional capacity. So that's kind of what's clinically driving me. I mean, that's my why I do all these 400 things at once. But I get to prevention eventually. Yeah. Okay. I will. But yeah, no, I think if we could look at markers in the blood, that would be a fantastic idea. So we'll talk.